He's an excellent rheumatologist, as we all know, and a very good soul. And he's going to give us a talk on rheumatic disease advanced therapies. Will be, and I want to really specially thank him because he is sitting in the medical staff office today. We were trying to do it in the green room so we can combine the live versus remote, and so we can have more of the audience participation. Hopefully, we'll have that news for you in the next few months. In addition to that, we have on 13th of May, which is I think Thursday, second Thursday of the month, we'll have our tumor board, and so majority of the people who have been coming, you know that it has really improved and it's great. So we really appreciate your attendance. In addition to that, we have a special talk next month on the CME, which is on Mycobacterium avium or atypical mycobacteria. We'll have a guest speaker from outside, and the CME also is being given by those. So it's very important to fill out papers, what are given to you after completion of the talk. And please do reply to Lachey, and we're trying to, hopefully, I keep on saying now it becomes redundant, that you should be able to answer a couple of questions on your computer, and you should get CME. But I've talked to a couple of people, so let's see with the IT, which is very rudimentary, can be improved. Thanks again, Dr. Farujas. It's all yours. Dr. Farujas has just told me regarding answering questions that he will take if there are burning questions during the talk. Otherwise, you can wait till his talk is over. Thanks, Dr. Farujas.
Thank you. And thanks to Ms. Gandhi. And thanks for the audience, especially the last person that just signed in, Dr. Elliot Gross. I haven't seen him for a few months. And I missed you all the past year. We all went through some difficult times. So I start my first slide as a meeting that I had with the President of American College of Rheumatology and President of European College of Rheumatology in 2010, when they came up with diagnostic criteria for rheumatoid arthritis after 100 years. So we came up with a specific guidelines. And now we all are in the same plane, and we know which patient is defined as rheumatoid arthritis for early diagnosis and treatment. As I will show you in the slide, it is imperative that we diagnose the condition early. Dr. Shirin Gabriel now is the Dean of Medical School at Rutgers. Next slide, please. So first slide covers COVID-19, and that's the only slide that I will show in COVID-19. This was published a couple of weeks ago at the British Society of Rheumatology. And they looked at a couple of hundred people, and then they came up with this, that there's no difference in antibody titers against COVID-19 in patients with autoimmune disease and without autoimmune disease. They didn't mention about the treatments that these patients were on. But we know when the patients are on prednisone and methotrexate, we'll cut back for a few days. Also, the other drugs that we cut back for a few days around the vaccination include the oral molecules, like the ones that I will mention. And technically, these patients are a little better off than patients without autoimmune disease when they go through COVID-19, and they don't get as much hospitalization or pneumonia, or they need less respiratory support. As you know, CDC had some specific clinical trials. Some of these trials included antibodies that we use for rheumatoid arthritis, including anti-IL-6. Next slide. When I started my practice in Culver City after finishing fellowship at UCLA, the treatment that we had for patients with rheumatoid arthritis was prednisone and gold shot. Those days are gone. Those days are long gone. And instead of that, you'll have patients with normal looking hands and they're not as much disabled. They're not on wheelchair anymore. Next. I should be covering these conditions, including rheumatoid arthritis, ankylosing spondylitis, psoriasis, vasculitis, Sjogren's syndrome, scleroderma, osteoarthritis, osteoporosis, Behçet syndrome, giant cell arteritis, psoriatic arthritis. The only category that I will not cover will be the muscular diseases, like polymyositis. So here, our learning objective is to learn about the biologic drugs and small molecules that have been approved in the past 20 years for treatment of rheumatic diseases. And it's changed the natural history of rheumatology or rheumatic diseases. So a good clinician spends time with the patient, checks every new patient I see, I check them for psoriasis because there's 7 million people with psoriasis, and a third of those will have arthritic condition or tendinitis or back pain or spondylitis or digits that are swollen and they're suffering. Rheumatoid arthritis, as I mentioned, has a specific guidelines for the diagnosis. You need 6 small joints like MCP joints or MTP joints. And osteoarthritis, we all know, and gout is a little different presentation. Next. The groups of treatments that we use, and we learned from oncology friends, the first was immune suppressive agents that we started using in the 1980s. And these can affect multiple cell lines. And then subsequently, we learned about cytokines, and then we came up with anti-cytokine therapies. And more recently, in the past 8 years, small molecules that target receptors on the cells, inflammatory cells. And now, after so many years, we have biosimilars, which are sort of similar to the original biologic drugs. And then many insurance companies are only covering the biosimilars and not the original drugs. But the pharmaceutical industry is clever, and they've come up with ways to provide the original drugs for the patients. Next. In the 1940s, nitrogen mustard was used for lupus, and then steroids were discovered in the late 40s, and Nobel Prize was given to Mayo Clinic scientists. And we still use these drugs, and we know small dose of prednisone may be a disease-modifying agent for rheumatoid arthritis. However, numerous side effects. So we tried to use it very little, and now we use it only as a bridge for treatments while we change patients from drug to drug. Cytoxan and chlorambucil are used very little. Cytoxan for lupus nephritis. However, methotrexate has remained and is gaining ground as the drug of choice and gold standard for treatment of rheumatic disease, especially rheumatoid arthritis. Other agents like immuran, azathioprine, and mycophenolate are used a great deal, mostly in autoimmune diseases like lupus and overlap syndrome. There is a drug that is not too dissimilar to methotrexate, leflunomide. It comes currently from China, and we use that sometimes when the patients cannot tolerate methotrexate. The last group you see here is gaining ground in lupus, and I will mention about lupus nephritis. So now we have 2 new drugs in the past few months approved for lupus kidney disease. Next. As I mentioned, methotrexate is the gold standard. It's a once-a-week drug. We prefer to use it as an injection. It inhibits DNA synthesis. We must give them folic acid supplement. Similar to leflunomide, there's more rash. Both of them can cause liver issues and low white blood count or platelet count, so we need to monitor blood tests regularly. We used to monitor them frequently and even do a liver biopsy on those, but that's past. We don't do that anymore. every 2 months in average. If they're on a higher dose, maybe a little more frequently blood tests. Sulfasalazine is a drug that was developed in the 50s, and the Europeans used it. However, here, when we can't use biologic drugs, we use combination of all of these drugs, and we call them triple therapy. 3 of these drugs can be combined together, and if you maximize therapy and treat to target, you can achieve some 30% remission in patients with rheumatoid arthritis. That's before we recognize where cytokines are, or bad cytokines, good cytokines, and we learn that there is an imbalance of cytokines. There is excess of sort of pro-inflammatory cytokines in rheumatic diseases and not enough good cytokines. We recently learned that there is a couple of cytokines that have both anti-inflammatory and pro-inflammatory effects, and one of them is IL-10. So that's being investigated as we speak. And here you see not enough IL-10, but excess of TNF-alpha, IL-17, IL-6, that causes inflammation. In the beginning, next slide, please, we learned that there is about 50 disorders that are associated with excess in pro-inflammatory cytokines. Peter Sinai interviewed Mark Feldman in the 80s to make him the chief of rheumatology, but he turned it down. He was the chief of Kennedy Institute of Rheumatology, and they studied infliximab, which is Remicade. And that was the first drug that was approved as a biologic agent. We still use it. It has advantages, and one of the advantages is that it's an infusion therapy. You can use it every 2 months, but every 6 weeks or every 4 weeks, 3 mg per kilogram, 5 mg, or 10 mg per kilogram. I was the first rheumatologist to infuse this agent in the office here in Culver City, in Los Angeles, actually. And then we still infuse it, but I've stopped infusing patients in the office. They go to infusion centers, a variety of places. This is a chimeric antibody. Chimeric means that there's a portion of the molecule that is used is from mouse. And I will show you there's another drug with that is chimeric also. There's 5 drugs that are fully humanized, and they're sub-Q injections that are approved for rheumatoid arthritis. And we use them regularly on patients with rheumatic diseases, especially rheumatoid arthritis and psoriatic arthritis. The drug that is very different, if I can show, is abatacept. Let's go back. Abatacept is a very interesting molecule and inhibits T-cell proliferation. Then we use IL-6 drugs and rituximab. Psoriatic arthritis has an advantage that in this group of diseases, which is not uncommon and is perhaps in a differential diagnosis of any new patient that I see in the office, we have a group of drugs that are anti-IL-17, IL-12, IL-23, and they're amazing drugs. They put patients in remission, especially with their psoriasis and subsequently their psoriatic arthritis. So these are the generic names for these monoclonal antibodies, and I have patients on every one of these drugs, and there's competition between the drugs in various areas, but we've learned the ones that monoclonal antibody, they cover gut disease too, like colitis. The first one, Enbrel, doesn't cover colitis or inflammatory eye disease. So we're learning subtle differences between these drugs. The IL-1 drugs we don't use as much because they're daily injections. Anti-IL-6 drugs are highly successful drugs. You don't need to combine them with a methotrexate, unlike anti-TNF drugs. And the most cost-effective drug for rheumatoid arthritis, it appears to be rituximab, which is an anti-CD20 infusion every 6 months. Amazing. The latest oral agents include kinase inhibitors, Janus kinase inhibitors. There's 3 of them on the market, and I have hundreds of patients on those. Reasonably well tolerated, but they have to be monitored regularly like biologic drugs. And they have to be vaccinated beforehand, specifically for Shingrix and pneumonia. The last agent you see on this list is apremilast. Is an amazing drug that you don't need to do specific blood tests for TB. Let's go back, or you don't have to worry about the infections. You don't need to do blood tests on these patients. It's an oral agent, and it's approved for 3 conditions: for psoriasis, for arthritis of psoriasis, psoriatic arthritis, and also it's approved for Behçet syndrome. If you, yes, Dr. Ms. Dandy has a question.
I have a question. I know that you're talking about psoriasis. Are we talking about all psoriasis, like scalp psoriasis? Will it help with that?
Yes, this drug is shown data that it's highly effective for scalp psoriasis and even nail psoriasis. It takes time, up to 3 months, an oral agent. Let's go to the next slide. In this slide, I show you the infliximab portion that is a mouse molecule. We call it a chimeric antibody. And the one that you see down below, certolizumab, is a drug that is extensively studied in women, young women with pregnancy, and there's no issue to take this drug during pregnancy and also with lactation. Now we're learning that the rest can be used as well, but they haven't spent the money and time to study these drugs. The other thing we learned about these drugs during the pandemic, it's okay to continue these biologic drugs during the vaccination of COVID. The only 2 drugs that we take holiday, or 3 drugs, is prednisone, methotrexate, and oral kinase inhibitors. More of these antibodies and their shapes and their work and then their function, and which is a little too detailed. I'm going to skip this. And we've learned that methotrexate is the cheapest drug. Injectable methotrexate is the best drug. All biologic drugs need to have methotrexate on board except Orencia and anti-IL-6 drugs. And at UCLA, when I was a fellow, we had an attending, Dr. Harold Hollis. Hollis came up with a way to assess patients' well-being, and he called it Hollis criteria: 20% improvement, 50% improvement, 70% improvement. And he passed away about a couple of years ago. He was an emeritus and founding member of the American College of Rheumatology, who adopted his criteria, and now they call it American College of Rheumatology criteria for improvement, up to 90%. We've learned that window of opportunity to control the rheumatic diseases is early diagnosis. So it's important to clearly identify what's wrong with the patient for treatment. And we've also learned that 80% of rheumatoid arthritis structural damage in the joints occurs in the first 2 years. So early intervention. In the 90s, early 90s, we had patients that were disabled, they were on wheelchair, they were unable to go to work. Now with these drugs, we see patients are working, they're less disabled, and then they have less surgery, and then they have sustained improvement. They don't take as much pain medications. And a friend of mine who's a very busy rheumatologist, he has 3 rheumatoid arthritis patients that do triathlon, and it was unheard of 20 years ago. 80% of the drugs that we use after sophisticated biologic drugs are anti-TNF drugs, since they've been around for a longer period of time. This is an agent I told you earlier about, an oral drug, small molecule, increases intracellular cyclic AMP. As you know, there's 9 classes of phosphodiesterase E inhibitors. Theophylline was phosphodiesterase 1. Viagra is phosphodiesterase 5. This is a phosphodiesterase 4 inhibitor that affects inflammatory cells and reduces the pro-inflammatory cytokines and improves yin and yang of inflammation in patients with psoriasis, psoriatic arthritis, and now we know with Behçet syndrome, which is rare. However, if you're Japanese or Middle Eastern, Turkish, Persian, Israeli, you see Behçet disease. I think there is a few hundred patients in California only. There's no laboratory test monitoring for this drug, and there's no drug-to-drug interaction. So this is the one that I like. This agent, as one drug, was exchanged between 2 pharmaceutical companies for an amount that is unbelievable. $13 billion was spent to acquire this drug, which you see the advertisement on the TV for. It's called Otezla. So after non-steroidals, this drug, Otezla, is approved for psoriasis and psoriatic arthritis. So here, none of these secondary line agents, methotrexate, sulfasalazine, Arava, non-steroidals, they were never studied in psoriatic arthritis, but we use them all. And we still don't have data about their broader response to these drugs. But apremilast or Otezla was extensively studied in several hundred patients in at least 4 detailed clinical trials that went on for 3 years, and now we have data for up to 8 years. All the injectable TNF drugs are approved for psoriatic arthritis, plus 2 IL-17 drugs that are on the market, perhaps a third one that has a limited use, Silic. And then there is one IL-12/23 that we use every 3 months as an injection. And that drug is being looked at for lupus as well as for inflammatory bowel disease. There is 2 anti-IL-23 drugs on the market for psoriatic arthritis. And there's a third one that is going to be approved by FDA within the next couple of weeks. That drug, 4 times a year, highly, 90% improvement in psoriatic arthritis patients. What happens with this drug, 4 injections a year, what they did with the second year, they stopped the treatment. At the end of 2 years, so only 4 injections, at the end of 24 months, 80% of the patients had good response to the original 4 injections. Psoriatic arthritis, compared to rheumatoid arthritis, has less infections and less malignancy. So as you know, RA patients by themselves have a little more lymphoproliferative disorders, and we have to monitor the patients. These people with psoriasis and psoriatic arthritis, almost every one of them I share with a cardiologist, because there's a higher incidence of silent coronary artery disease in patients with psoriasis, psoriatic arthritis, and the family members, first-line family members. A pearl here, a medical legal pearl, underlined in yellow. Trauma can initiate psoriasis and psoriatic arthritis and aggravate psoriatic arthritis, ankylosing spondyloarthritis, osteoarthritis, fibromyalgia, and that should be kept in mind. I see 5% of my practice is workman's compensation, and I see that almost regularly. So as you know, ankylosing spondylitis, unlike rheumatoid arthritis, has been around for 3,000 years. When they did CAT scans on the mummies of Egypt, they found these diseases, usually younger population with inflammatory back pain and morning stiffness, and they end up losing movement of the spine. The inflammation here, unlike rheumatoid arthritis, has two parallel mechanisms. One is cytokines like TNF drugs or IL-17 drugs. The other one is old-fashioned prostaglandins. So all these patients must be on combination of non-steroidal anti-inflammatory agents plus an anti-TNF drug or anti-IL-17 drug. So we know these drugs are associated with more injection site reaction, up to 5%, more infection. Sometimes it could be serious infections like sinusitis. And then if you see a patient who develops sinusitis in these drugs or upper respiratory infection, you have to move on to some secondary agent and find out why the underlying condition is. All these patients must be vaccinated fully for pneumonia, flu, and Shingrix before they start. You remember earlier I said there's 50 different diseases that are associated with excess cytokines. Mm-hmm. One of them is congestive heart failure. They tried these drugs for congestive heart failure and their heart failure got worse. Now, heart failure is a contraindication in patients that may use TNF drugs. Hepatitis screening is important. We don't give it to patients who have hepatitis B. They have to be treated and controlled before we give them. TB screening, of course, it's an important component, and we used to see this earlier, but now we don't because everybody gets either gold quantiferon test or TB spot tested. So besides psoriasis and ankylosing spondylitis, these agents are used in colitis, ulcerative colitis, inflammatory bowel disease, except Enbrel. In uveitis or non-infectious inflammatory eye disease, there's adalimumab or Humira approved, but we use other agents as well, except Enbrel. Some of these drugs are approved down to age 2 years old for patients with juvenile inflammatory arthritis. Pediatrics use of these drugs have been studied. Off-label, the drugs have been used and successfully treated patients with sarcoidosis. As I spoke with you earlier, sarcoid is one of the conditions that the newer tyrosine kinase agents can be used. IL-6 drugs, Actemra and Kevzara, that were used in the past year in patients with COVID in clinical trials. Now, other than RA, they're approved for temporal arteritis, giant cell arteritis. So I've had 3 patients that I've treated with these drugs. We were able to taper their steroids faster with these agents. And their laboratory tests like SED rate, C-reactive protein quickly becomes negative, and then anemia that they have improves. They have their own issues. You have to be worried about infections and that sort of thing. And they come in sub-Q injection and also in the form of infusion treatment. They've been looked at for use in scleroderma as well, lupus as well, and polymyositis. But the drug that we use in polymyositis more often than not is IVIG. These drugs can cause diverticulitis or abdominal issues, so liver enzyme elevation and cholesterol elevation, but the ratio of cholesterol good and bad cholesterol does not change in these patients. As we know so far, we've learned with use of these biologic agents, the incidence of atherosclerosis in rheumatoid diseases has diminished. This agent, or Orencia, abatacept, is the one that has no black box warning. It's a very safe drug for rheumatoid arthritis, psoriatic arthritis. It's once a week sub-Q injection. It inhibits CD80, CD86, and then the molecule, it's a cytotoxic T lymphocyte-associated antigen, CTLA4. Versions of CTLA4 are on the market for oncology cases. And this is how it works. It works on the antigen-presenting cell and its interaction with T cell and blocks CD80, CD86, and CD28 and prevents proliferation of T lymphocytes. The angry pink T lymphocyte becomes a normal T lymphocyte, as you see here. Rituximab, which is the most cost-effective drug for rheumatoid arthritis, has numerous uses and indications like RA, lupus, and now oncologists use it for different kinds of lymphoma, and it's CD20 cell inhibitor. The newer drug that is being approved for lupus and lupus nephritis is belimumab, which is a monoclonal antibody against B lymphocyte stimulators inhibitor. And it's called Benlysta. It comes infusion and sub-Q. Rituximab, as I mentioned, is a chimeric antibody against CD22. This part is a mouse molecule. And it's, as I mentioned, used for lymphomas. And it's comparable to all other biologics, except because we can use it every 6 months. It's highly effective. The other indication for rituximab is the old-fashioned ANCA-associated vasculitis that has a new name, ANCA-associated vasculitis. The old name is Wegener's granulomatosis. Wegener's, who described the disease, was a Nazi. That's why they stopped using the term, and the now ANCA-associated vasculitis, the new term. You pay attention in the next few slides. I will tell you about 2 new diseases that were described in the past 5 years. One of them is IgG4-related disease, and rituximab is highly effective drug in that condition. I will tell you about that in the next few slides. Sjogren's, polyneuropathy of inflammatory type, aggressive lupus, pemphigoid, autoimmune hemolytic anemia, immune thrombocytopenic purpura ITP, and IgG4-related disease. This drug is being used. So Wegener's or ANCA-associated vasculitis is not the drug of choice for infusions in a row and tapering steroids. As you remember, this disease in the 70s had no treatment other than prednisone, and the patients died within 8 months of the treatment. And UCLA was the first institution, but publication was by a fellow by the name of Michael Reza that I worked with. He's now in the other world. Michael Reza was a pioneer in treatment with Cytoxan before we had the Rituxan. And this treatment was adopted by Anthony Fauci. Fauci published subsequent to Michael Reza about webinars and treatment with Cytoxan, and it became world famous. And then subsequently fell into HIV, and then went into government, and he's been there for 40 years. He's a very good teacher, but in the past few months, I'm disappointed because he's not giving full information to the public. He should be more open. So Rituxan is used in this potentially deadly disease, pemphigus, and I've learned that there's a specific antibody for this condition, and desmoglobin alpha 1 and 2. I guess in the hospital when they see I saw a patient here about 2 years ago in the ICU that was ultimately had a bad outcome. However, outpatient early treatment with Rituxan, these patients get good results. Remember I told you about this new disease that was described by a Dr. Stone at Harvard. And if you go to YouTube, he has extensive presentations about this condition, IgG4 related disease. These are people that show up in the clinics with multiple complaints, including aches and pains and body discomfort, and they can have other manifestations like fibrosis in the retroperitoneal area, or soft tissue infiltration behind the eye, pseudotumor in the brain, or these nodules on the mandible, neck swelling, or they can have pancreatitis, pancreatic mass, and hilar lymph nodes or hilar nodules. These patients respond dramatically to Cytoxan. So that's one new disease. So you can measure IgG4 as separate blood tests besides quantitative immunoglobulin level. Disease category that I published in the 80s with Honorable Dr. Wallace. I will show you a picture of Dr. Wallace and me. And we published 2 articles in Green Journal and American Journal of Medicine about survival of lupus patients with nephritis and without nephritis. Now has a few drugs that we use more frequently, Benlysta or belimumab, which is monoclonal antibody, sub-Q injection or infection, Rituxan, tacrolimus, and that tacrolimus has a new drug that came out about 4 months ago, loop kinase for lupus nephritis. It's a cyclosporine analog, and Cellcept, and it's widely used in autoimmune diseases, especially lupus. In the next few months, we have an antibody against interferon alpha 1 for lupus patients, and now they're in clinical trials. This agent, I think they stopped clinical trials in lupus. Benlysta was the first drug that was approved by FDA after 6 years since hydroxychloroquine was approved in 1974. And then before that, prednisone was used. And now we see movement in this area. A cyclosporine analog and also the anti-interferon drugs. 40,000 people have been infused with this drug and injected, and it's well tolerated, up to 70% response. And now it's approved for lupus nephritis plus this drug, which is called leukinase or volcosporin, oral agents, and if they have reduced glomerular filtration, will reduce the dose. You see, put a couple of slides here of anti-nuclear antibody. The higher the titer and the higher the anti-DNA and lower the complement, it is more active disease. We've learned to measure complements with a different technique now. Instead of free complement, we measure cell-bound complement, which is more accurate, and we can cover that in an earlier. Psoriasis, psoriatic arthritis, there's 40 different forms of it. As you see here, there's 7 types of skin condition with several types of clinical presentation like tendinitis, back pain, spondylitis, dactylitis, digital sausage joints, or polyarticular arthritis, or rheumatoid type picture, or even arthritis mutilans, which digits get short. I'm sure you've seen some of those cases. These are the various patterns of. So as I mentioned, every new rheumatic disease patient I see, I examine their scalp and their nails. Right away, I will get to the diagnosis of psoriasis-related arthritis, which is not uncommon. And you see a whole bunch of drugs have been developed. The reason is clinical trials that are mandated by FDA are easier outcomes compared to rheumatoid arthritis. In rheumatoid arthritis, they have to show X-ray improvement or X-ray prevention of damage. Here, those strict criteria are not there, so most drug companies are approaching a more common condition, psoriasis, psoriatic arthritis, and this field is growing a great deal. And you see their trade names here and then generic name of these drugs. The next category of these agents that have been used in the clinical trials for about 10 years now, and they're on the market for about 7-8 years, and we have data, are kinase inhibitors. This is a schema of kinases in our body. These are several hundred kinases that now about 50 or 60 of them are used in oncology and hematology. We had 4, now we have 3 of them in rheumatology, and there's a variety of those. I'm sure they can all affect rheumatoid arthritis, but they're not looking at rheumatoid arthritis because it costs a lot, and the criteria or doing the clinical trials is very costly. So they inhibit or prevent intracellular reactivation of pathways that lead to inflammation. JAK drugs, JAK by itself means gatekeeper. It's the gatekeeper that prevents the inflammatory process from getting into the cell. And there's several types of it. JAK1, JAK2, JAK3, and the JAK4, we call it tyrosine kinase 2, as we mentioned earlier. Tyrosine kinase is now approved for inflammatory lung disease. So that's how they work. For 3 of these drugs we use on a regular basis, and they have their own specific values, and they've been studied extensively, except the one on top. They did post-market analysis of several thousand patients. They realized the patients have a higher incidence of coronary events, small amounts, but nonetheless important, and higher amounts of cancers. So on those patients that I've had on this drug, I'm using the drug because they go in remission with 1 pill a day. I use it every other day to reduce potentials of the other 2 drugs have not shown these, but all of these drugs are associated with viral infection, especially zoster, and blood clots. So we have to be careful with blood clots. COFAR is the drug I told you about, and we heard about this. This slide shows who gets serious infection with these agents. Higher age, a higher positivity of rheumatoid factor. If the patient has rheumatoid nodules or the sedimentation rate or C-reactive protein is very high, or if they have low white blood count. Felty syndrome, you remember that? And if they're diabetic, alcoholic, or they have chronic lung disease and other serious conditions, they can develop infections, UTIs, that sort of thing. We have to be careful with each patient. Here's a slide of a patient with tuberculosis in the upper lobe, and both these biologic drugs and oral small molecules can increase the risk. So we check these patients with the test that I mentioned earlier, called quantiferon and T-spot. T-spot now is done by Quest Laboratories. In many clinical trials, they showed 13,000 patients, 49,000 patient years between 98 and 2005. There was no increased risk of lymphoma, lung cancer, breast cancer, and colon cancer with biologic drugs. However, there was a slight increased risk for non-melanoma skin cancers, like squamous cell cancer. So, William, this is the drug that we like to use in patients who may get pregnant. Biosimilars may be not a financial advantage for the patient. Therefore, the original drugs have been able to extend their patent, like for Humira, even though if the competitor drug is available in the form of a biosimilar, and that's still extended until 2028. It's the most successful drug for rheumatoid arthritis. I can't give this presentation and not cover osteoporosis because there's dramatic changes in treatment of osteoporosis. Because when I was medical director here at Broadman, I saw thousands of patients with fractures, mostly result of osteoporosis. Here's a compression fracture of the vertebral body, very painful, and the fracture hips and surgical approaches for fracture hip, fracture pelvis as well. And now the latest drug is sclerostin inhibitor, or Evenity. It works on the Wnt pathway and it has dual action. It's mostly anabolic, and the bone that it builds is unbelievably strong. So they approved it for 12 injections, once a month for 12 months. After that, you use one of the other approaches below, like giving them back the old-fashioned Balsamax or alendronate or drugs in that class, or Prolia or denosumab, which is a rank ligand activator. And these two drugs, abaloparatide and teriparatide now is, Forteo is gone generic. Timlos, the competitor, is half as many as a smaller molecule, but it's as effective. It's half as expensive. Timlos is an anabolic agent, but it's a daily injection. Both of these drugs are daily injections, and within a month or two, the pain associated with fracture improves on these drugs. So now, spine surgeons prefer to treat patients beforehand, before surgery, with one of these two drugs. I don't know if you heard about this, but I need to mention this. Atypical femoral fracture is a side effect of any of these drugs that are used in osteoporosis, specifically bisphosphonates. I had, throughout the years, 5 or 6 patients that came to see me. They were on Fosamax. for 5 years, 7 years, 8 years, and they had severe hip pain. They couldn't, all of a sudden, they couldn't get up. And when we took X-ray, there was a beak right over here. These patients are high risk for fracture like this. And once you see these patients, the treatment, 25% is bilateral. You have to put a rod preventively to develop this kind of fracture. So this atypical fractures can happen if patient is on bisphosphonates for many, many years. So typically we keep them on those plasma-spike drugs for about 3 years, 4 years, and then we switch modality of therapy. We give them drug holiday and we go to other modalities. Remember, atypical femoral fracture. This is a second new condition that I'll explain to you here. There is a couple more. So this is sclerostin inhibitor, Evenity, 12 injections once a month. It's strongest of all drugs for osteoporosis. These are the molecules of these drugs. These are not small molecules, and mostly monoclonal antibodies. And the old drug that was approved for osteoporosis was raloxifene, which is like tamoxifen that we use for breast cancer and estrogen receptor positive breast cancer patients. We call this class of drugs the selective estrogen receptor modulators, or SERMs. It's approved for osteoporosis, but it's not used as much because it's associated with deep vein thrombosis. So you don't want to treat a patient for osteoporosis and give him stroke. So the patients need to be monitored carefully. I must mention this drug here because if you have a gout patient with tophi, white chalk deposits all over the place, in their ears, on their elbows, on their joints, on their feet, and allopurinol doesn't work even up to 800 milligrams. This drug, Cristaxop, pegloticase, has been around for 10 years now. I infused a few patients on this. Within a few weeks, these lesions melt away. The monosodium urate transform into a allantoin, and they get excreted in the kidney. It's remarkable, except the side effect of this drug includes some anaphylactic reaction. So when you give these agents to the patients, their uric acid drops dramatically from 14, 13 to 1 and 2. And you can predict which patient will develop anaphylaxis. If their uric acid doesn't drop below 10, those are high-risk patients. Now they've come up with modalities to prevent those. They give them either steroids, methotrexate, or Celcept to prevent these reactions. Successful. One anecdote I'll tell you about a patient of mine that went to get an infusion of Cristaxol in an infusion center because it takes 2 hours to infuse. He was exposed to COVID. He developed COVID in the infusion center, but he recovered. One new disease and condition that is recently described, I must mention, this is called non-radiographic axial spondyloarthritis, NRAX spondyloarthritis. These are the patients that have inflammatory back pain. They think there's 1.7 million people with this condition. These people have pain during the night. They wake up in the morning stiff, and they are always in pain. And with exercise, they get better. That's called inflammatory back pain. They can start with pain in sacroiliac area, which is buttocks. So first question, in somebody who has back pain, do you have buttocks pain? And if they say buttocks pain, you take x-rays of the sacroiliac joint. These people with non-radiographic axial spondyloarthritis, they have negative x-ray of the sacroiliac joint or spine. However, if you do an MRI, they have findings of sacroiliitis on the MRI, or early syndesmophytes that is seen in patients with ankylosing spondylitis. So we call this a non-radiographic axial spondyloarthritis. The reason I mention this is that these people with back pain and normal x-rays, now there's 2 biologic drugs approved for this condition. One is Cosentyx, which is anti-IL-17, and the other one is a TNF drug, certolizumab, for Cimzia. So I'm sure the rest of these drugs can approach this condition and get approval for this. So not everybody has radiographic ankylosing spondylitis. By the way, I published on this condition a while back, and people, if they're not controlled with the two modalities I mentioned, prostaglandin inhibition and cytokine inhibition, they develop drug addiction. They get narcotics, pain. They become alcoholics. They drink to control their pain. One final slide on osteoarthritis. In the immediate future, there's a drug called tanezumab, which is an anti-nerve growth factor. It was studied, they let it go, and they picked it up again, and the FDA is looking at their data. It may be approved within the year for osteoarthritis. It's another monoclonal antibody against nerve growth factor, tanezumab. This slide was taken when my office participated in fundraising for Arthritis Foundation. Since the office raised more money for them than other offices, they put a banner for our office, for this family, and they used it for a few years. The end of this month of May, there is going to be a fundraising event, also a walk at UCLA. I mentioned earlier about the guru of lupus, lupologist, man of the century, Dr. Daniel Wallace. And I, in 1981, received our American College of Physicians recognition and became fellows of the American College of Rheumatology. And I'm in touch with him on a regular basis. Yesterday, I called the condition Wallace syndrome, which is a form of arthritis called CREST syndrome associated with anti-mitochondrial antibodies and Sjogren's syndrome. It is indeed an honor and privilege to have known the physicians in the division at Rheumatology Service at UCLA and Cedars-Sinai. And I want to give recognition to them because they formed my bedside manners here. I learned medicine from them and brought the service to Culver City for the past 4 decades. Once again, thank you very much for allowing me to be with you in the past few minutes.
Thank you, Dr. Farjash, for a real detailed presentation. I think anybody who has questions can unmute themselves, but I would start by thanking you. But in addition to that, are there any differences in the patients with rheumatological diseases and lung involvement in which you choose a different biological agent?
Yes, as you mentioned earlier, this past couple of years, has been a remarkable change in our approach. We've learned there's different types of inflammatory lung disease associated with fibrosis, and some of them are seen with rheumatic diseases, especially with scleroderma and diseases like scleroderma. In scleroderma specific, there's a new drug approved by FDA, and I have a couple of patients that have responded very well. Their lung functions have improved, their DLCOs improved, their need for oxygen is diminished. and also they're looking at other agents now. One thing I learned in rheumatic diseases that are associated with inflammatory lung conditions, a lot of these people have silent aspiration. So all these, there is data that shows use of PPI reduces mortality on patients with inflammatory lung disease associated with rheumatic diseases.
Okay. In addition, how long do you follow the patients in terms of TB screening or hepatitis screening, or over a period of time, and how long do you treat these patients?
As you know, beginning before we start any of these drugs, we check them for these, and
how often
the
do
thing
you
is,
check
and
them?
that's a very good. Every time I change the drug to a new class of drug, we check them again. And if we stay on the same drug, I would do it anywhere between 1 to 2 years. I'll repeat their TB and hepatitis panel again. I can tell you I've had half a dozen cases that didn't travel anywhere. They were at home most of the time. They were on one of these biologic drugs, and their T-spot or gold quantiferon became positive. So we had to stop the medication, give them INH or some Thambutol or something, and then resume the treatment a few weeks after that. In the beginning, if they're positive and the chest X-ray is negative, what we do is we give them the INH-like drugs and then wait for 1 month and then use the biologic drugs.
And how long do you, let's say you have a rheumatoid arthritis patient and has responded to your treatment, how long do you continue the treatment? Is it a lifelong treatment, or you cut down on the dosage, or you
That's
stop?
a very, very good question, because these drugs, first of all, they're not cheap, they're expensive, and there's some inconveniences. They have to be monitored and that sort of thing. They did clinical trials by reducing the doses to half or half frequent, and within a year or two, the disease did not change. And now that's the approach we use: gradually taper these patients and monitor them regularly. So there are patients that go off of it. As I mentioned in the other drug, Skyrizi, for psoriatic conditions, and 1 year of use, the second year, at the end of the year, was still 80% effective. So we're learning as time goes by with individual drugs. These are not to be used lifelong. And the earliest we can taper them off is when there is 6 months of no symptoms, no pain, no morning stiffness, negative sedimentation rate, negative C-reactive protein for 6 months, then we can take them off.
Great. Anybody else has any questions? Some of them are muted, so please unmute yourself if you have a question.
I have a question.
Yes, Dr. Gilani.
Thank you very much, Dr. Firuzesh, for this excellent presentation and so comprehensive. I have a question for a long time that I don't know if ingestion of animal protein may cause autoimmune disease or not.
We don't know specifically in that regards, but with people who have inflammatory arthritic conditions, they've used fish oil, especially fish oil infusion, and the patients went into remission. So diet and exposure to anti-inflammatory diet, Mediterranean diet, is very helpful. Obviously, sugars and high-calorie diets, they're pro-inflammatory. Overweight people have more inflammation. By the way, there is a blood test that measures multiple cytokines to detect activity of rheumatoid arthritis. It's 12 cytokines. One of these cytokines they measure is leptin. And leptin, as you know, associated with the obesity. And metabolic conditions can be associated with inflammation. So now we know inflammatory issues are more widespread than the joints and skeletal system. You can have inflammation of the coronary arteries, so acute myocardial infarction. They had a study at Cedars-Sinai. They were using methotrexate to see if patients had a heart attack. This methotrexate will inhibit subsequent, but I think they stopped the studies because they didn't see any efficacy in that. So the most effective anti-inflammatory drug in these atherosclerotic conditions is statins. I had a patient who had rheumatoid arthritis and arteriosclerosis. She was 90 years old, very alert woman. We had to slowly amputate her toes, midfoot, ankle area, and then statins became available. And then she had 2-3 strokes in between. As soon as we gave her the statins, all of these inflammatory atherosclerotic events diminished, and she lived 15 years beyond that. She was 104 or 5 when she died. So she had one leg, but she didn't develop further ischemic events. Now we're learning there is a group of drugs they're called, 2 of them at least, PCSK inhibitors, which is an antibody against this enzyme that is produced in the liver that causes production of cholesterol. PCSK inhibitors, 2 of them on the market, is every 2 weeks. One is called Troluent, and they reduce cholesterol by 80%. So people who have PAD and they may not respond to statins, or they cannot tolerate statins, we use PCSK inhibitors.
Thank you. Anybody else has any questions? Well, I guess not. So really, Dr. Farouchesh, thanks again for taking the trouble. We really appreciate it. And hopefully we'll have you back soon. Thanks again. And please don't forget to send the evaluation forms back and to get the accreditation too, and credit for the talk. Thanks a lot very much. Thank you again.
Thank you, Dr. Batra and Lashe.
You're welcome.
Bye.
Bye.
Thank you, Saul and Chris. Have a nice day.
Thank you very much. Elan, hopefully you're doing well, and I'll see you at the hospital